So my task today is to discuss future perspectives in imaging for left atrial appendage occlusion. So let's first ask ourselves, why is image-based planning and the guidance of the procedure so important? And this is because, and we learned that from Andrew today, we have an enormous anatomical variability. We have very complex 3D relationships, and the measurements for our device selection are derived from images. So devices require size matching and careful positioning with 3D alignment. On the other hand, if you have poor or inadequate imaging quality, this may most likely result in prolonged procedures, a higher radiation and contrast exposure for the patient, in a suboptimal device position, which means maybe on the long-term follow-up, a higher incidence of residual leaks and a higher risk of perforation or embolization. So what are the questions we have to answer with imaging? So first of all, we have to exclude contraindications. We also have to determine where's the LAA os. We have to see what is the distance of the left atrial appendage os to the mitral valve and the left upper pulmonary vein. We have to assess the shape and the size of the left atrial appendage ostium and the landing zone. We have to estimate the distance from our transeptal puncture site to the left atrial appendage ostium. We also have to evaluate the orientation of the central axis of the proximal left atrial appendage to the plane of the interatrial septum, because this may influence the choice of our delivery sheaths. We also have to assess the number and the location of lobes and the depth and the dimension of the anchoring lobe to do our sizing. So what are the future imaging strategies? So I discussed today TEE miniaturization, 3D intracardiac echo, echo and fluorofusion, CT and fluorofusion, and 3D prototyping. So let's ask first the question, what do you believe? The future in imaging is one of the answers below. Intracardiac echo plus fluoroscopy, echo, fluoroscopy fusion, echo only using nasal and microprobes with limited fluoroscopy, and fluoroscopy only. So please vote. So 4 more seconds to go. So very interesting. So let's see what we can say about the different imaging modalities. So let's start with TEE miniaturization. So this image gives you an imagination how small the microprobe TEE probe, as you can see it here, is compared to the standard TEE probe. So we get frequency ranges from 8 to 3 megahertz, and there is an adult gastroscope. So usually this probe is used in children, but there's an adult gastroscope which measures 85 millimeter, and it can be used in adults. So this probe can only be used or rotated manually from 0 to 180 degrees, and the anterior and posterior flexion is also only manually controlled. So we have the same modalities as we have with 2D TE, 2D pulse wave Doppler, continuous wave Doppler, color Doppler, and M-mode and harmonic imaging. And this probe, well, this is not an issue for our patients, but it can be used in babies and children which have a weight of less than 3.5 kilograms. So these images give you an estimation how the imaging quality with the microprobe is. So this is an evaluation of the left atrial appendage in 0, around 50, around 90, and 137 degrees. And I think you agree that the imaging quality is quite nice with the probe. So in this imaging, we see a bicaval view and a short axis view where we can see the tenting during the transeptal puncture. In the next view, we see the sheath coming across from the right atrium to the left atrium. And in this view, we see the comparison with and without color Doppler, the assessment after the placement of a Watchman occluder. So imaging quality is not bad with this microprobes. So we get a quite good imaging quality. The advantage is that we don't have the need for general anesthesia or a deep sedation for the patient. Therefore, it's more convenient for the patient. We can go for a transnasal access with this probe. It's possible. And we can treat patients which are really small. On the other hand, we have to keep in mind that it's still a semi-invasive investigation. It may be difficult with this very small probe to get good adhesion to the esophageal wall, so it might happen that we have less good imaging quality. It has to be maneuvered completely manually, which is a little bit You have to become used to it if you use a probe, and we don't have any 3D capabilities at the moment. And, of course, we have additional costs for the additional probe if you use it. So the next topic I'll cover very, very shortly. This is 3D intracardiac echo, and I think we got really great images and great cases from the previous speaker. So 2D imaging is an option for our procedure guidance. And just to give you an impression how a 3D image would look like. So this is from a publication published in 2014. So what you can see here is a very small angle, and that's a major limitation, I think, with 3D eyes at the moment, because the angles we can acquire is around 20 degrees. But it is possible to evaluate the left atrial appendage ostium, even to the neighboring structures, as we see here, the mitral valve. This is a rim between the left atrial appendage and the left upper pulmonary vein, and this is a visualization where the eyes catheter is placed in the coronary sinus, where you can also get an impression of the left atrial appendage ostium, the rim to the left upper pulmonary vein, and the entrance to the left upper pulmonary vein. Advantages of intracardiac 3D echo, just to summarize that. Well, an advantage is that we get real-time visualization. It's definitely more convenient for the patient than TE because he doesn't have a probe in his esophagus. There's no need for general anesthesia or sedation. We get reasonable good imaging quality. You don't need an additional echocardiographer because the interventionalist can steer and maneuver the probe. And your eyes catheter can be positioned in the right atrium, the coronary sinus, or on the pulmonary artery. So if you use 3D, that may minimize the need to place the eyes catheter at different positions during the procedure. On the other hand, which is one of the limitations, it's still invasive, and as we heard, you need an additional venous access for the procedure. It's quite expensive, and at least in Germany, I don't know how it's in your countries, we don't get any reimbursement for our eyes catheters. It can be used during interventions only because nobody would do an invasive procedure just to evaluate a left atrial appendage. And the interventionalist, therefore, needs to be familiar with the maneuvering of the eyes catheter. And as you've seen, we get a very limited 3D volume size, which is around 20 degrees in one perspective and 90 degrees in the other. So, and this means we don't get any wide angle acquisition, and we don't do the steering to the targets. And the 3D spatial resolution, as with all 3D options we have nowadays, is relatively low. So the next topic I would like to discuss is Echo-fluoroscopy. So we all know and are familiar with TE, and it's well established during the procedure. So we see some examples of the exclusion of contraindications here. We have a thrombus in a 3D aspect, which is mobile here at the ostium of the left atrial appendage. We see a mobile plug in the aortic arc over here. So this is a patient with a mechanical valve, and these patients need anticoagulation on long term anyway. So you wouldn't have a patient with a left atrial appendage closure. This is a patient with a typical mitral stenosis, and this is a patient where we have an atypical left atrial membrane, which is covering the ostium of the left atrial appendage. And this mobile part, what you see here, is not a thrombus. This is part of the membrane which is loosened and which is mobile. So TE is also well established for the procedural guidance, as we see here. So we have 3D and 2D imaging in one image, and this can help to guide your transeptal puncture. We use TE to guide our sheath position and to judge about the alignment of the sheath in the left atrial appendage. And as we can see here, we can very nicely observe the development. So in this case, we see the development of a 26mm ACP occluder. So at first, the lobe is developed relatively deep into this left atrial appendage, and in the next step, so we see the development of the disk of the device. And this can be done in real time. You can store it, and you can review everything after the procedure. So how could you combine both modalities, angiography and echocardiography? How does it work? And it works because the registration of the two image data sources, it's managed by tracking the shape of the TE probe in the Xray image. So what we have here is a model of the probe. And as you can see here on the right-hand side, the shape of the probe is tracked in the fluoroscopic image. And if you know the shape of the probe, you know where your 3D volume is positioned, as it is indicated here by this green pyramidal green lines. And these are the images you get. On the left-hand side, you see the perspective of the echocardiographer. This is an explained image on the left-hand side. On the right-hand side, you see fluoroscopy, and you see the overlay of the fluoro on the fluoroscopic image. And you see how nicely the interatrial septum can be estimated. This is a structure we normally don't see at fluoroscopy. And you see the needle, the transeptal puncture needle, which is coming down towards the fossa, and this can be observed really in detail by using this technique. So this is a similar situation where we have a 3D image on the right-hand side, and again, you see the puncture site, or you can determine the puncture site in the interatrial septum very nicely. On this image, we see the sheath, which is leading from the transeptal puncture site into the entrance of the left atrial appendage. And again, you have the overlay of the image onto the fluoroscopy on the other side. And you can very nicely decide if it's good aligned. As you can see here, so we have a nice alignment of the sheath within the left atrial appendage. So this can be very helpful. So advantages of this method, a big advantage is that we really get real-time fusion imaging. It facilitates the communication between the interventionalist and the echocardiographer because they see the same view, or you can have the same view of the same structure. It facilitates transeptal puncture. We have an advanced orientation in a 3D space, which can be relatively large, means the left atrial appendage. And this method, or this imaging modality, can improve navigation of wires, catheters, and delivery systems because we can get wide-angle acquisition. And it optimizes the targeting to our region, to the left atrial appendage. And we can also optimize our steering by using markers. So we could mark, for example, the left atrial appendage ostium. And this may potentially lead to faster procedures, less radiation exposure, less device maneuvering errors. And more or less, we may get a more accurate assessment of device placement and the final result. On the other hand, it needs a very specific equipment, and that's expensive. So it's only compatible with Philips. So you need a Philips angio and a Philips machine, a Philips echo machine, to combine these imaging modalities. The interventionalist needs to be familiar with 3D imaging because he has steering options along the table. The 3D options we get are relatively low concerning the spatial resolution, but that's what we have with all 3D imaging modalities at the moment. The next big topic is CT and fluorofusion. How does it work? So we know that CT is valuable for thrombus detection, for example, as we see here. It's also very helpful to assess the left atrial appendage anatomy. So we already heard that we can categorize several morphologies like the cauliflower, the chicken wing, and the windsock. And indeed, it could be shown that the left atrial anatomy might be useful in predicting stroke in patients with non-valvular atrial fibrillation who have a low risk score. And especially the cauliflower morphology has shown to be more frequently associated with strokes. So you can nicely do your measurements. You can measure the lobe length, you can measure the lobe angle, you can measure the distance to the first banding, which can be very important for your device placement, and you can measure left atrial appendage volumes. So for device sizing, it has been shown that the measurement of the ostial parameter is the most suitable and the most reproducible parameter for sizing in left atrial appendage occluder. And in this study, they looked for diameters, perimeters, and areas. And out of these measurements, the perimeter was the best for sizing. CT angiography can also be used to assess for residual flow, as we can see it in this view over here. So this was a patient where a leak was missed in TE, but on this side over here, you can see the contrast enhancement in the distal part of the left atrial appendage, thus indicating that there has to be a leak. So we also use CT, especially if you do a lariat procedure, because if you do a suture ligation of the left atrial appendage, you have to come via the pericardial space. And in this case, you have to look at the width of the left atrial appendage, which is assessed specifically with this procedure with CT. You have to look if the shape is compatible for snare placement. If you have two lobes which are directing in different direction, it's not possible to place a snare around the left atrial appendage from the outside. You also have to check if the left atrial appendage is located under a pulmonary artery. This would be contraindication. And you have to assess the best angle for your pericardial access. So how to combine now CT and fluoroscopy informations? And it's just one example, so there are several coming, but this is one example. This is a 3-menu software. So first of all, what you get is a 3D volume rendering, and you can assess the left atrial anatomy from the outside. For example, in this case, you see a nice chicken wing formation, so you get very nice information how your left atrial appendage is configured. You can do in the MP reconstructions, you can do your measurements, you can measure diameters, you can measure the perimeter, and you can measure your areas. The next thing you have to do is to mark, to place 2 landmarks at the ostium of the left atrial appendage. And according to these landmarks, you said, the system generates a ring which visualizes the ostium of the left atrial appendage. And in the next step, this ring, which is generated, I go back once more, is transferred to a simulated angiography, where you have the same impression which marks the ostium of your left atrial appendage. So in this example, we see a 3D volume, and you see the ostium is marked with a ring, with a bandage over here. And this left atrial appendage can be automatically isolated, and you can place it on top of your fluoroscopic image. So this, again, is a simulated angiography, but it helps to define the best plane for your intervention. So this might be helpful to say in advance, well, for this appendage, I would use this or this angulation. So this can be very helpful. Advantages of this imaging modality is that you can just do it very easily because it's a software package and it works with all major medical imaging formats of ultrasound and echo, fluoroscopy, CTA, and it can access multiple data stores on the network like CD, DVD, USB, and the internet. It may allow for better pre-procedure planning of our procedures. You get a very fast assessment of the left atrial appendage shape and the orientation in the 3D space. The application provides diameters along the left atrial appendage, and this ring we saw to mark the ostium may facilitate your orientation and your steering towards the left atrial appendage. The angle simulation enables you as well to pre-select the best plane for your implantation, and this may potentially lead to more precise, less invasive, and faster procedures. On the other hand, we don't get any real-time assessment for our procedures because this is done pre. We have additional radiation exposure because you have an additional CT in front, and additional costs because you have to pay for your CT and you have to pay for the software. The left atrial appendage filling conditions or the left atrial filling conditions are most likely unknown during your CT procedures. So the patients normally don't eat and they don't drink, so you don't really know if your measurements you do over there are really reliable. The last point I would like to mention is 3D prototyping. So just let's think about if you have a 3D volume rendering and you can print a prototype with soft tissue, which is similar to the tissue we have in the heart, as we see it here on the right-hand side. So this is something which could help because you can train in advance a procedure. This could help to optimize transeptal puncture location. This could optimize the sheath selection because you can have a look which is the best angle to come into this left atrial appendage. And it could potentially optimize the alignment of delivery catheters and landings in the landing zone of the left atrial appendage. And if you have such a model in advance, it could also help to look for the best size of your device, because you could have a look in advance if you have any residual leakage around your device in the specific heart. So to summarize, the future imaging strategies we saw here may potentially lead in future to more accurate left atrial appendage evaluation, to more convenient procedures for our patients, to faster procedures, due to a more accurate pre-procedural planning, maybe to safer procedures. So this would be a big deal, I think, if we could save radiation or contrast exposure for our patients. We may get more precise result, and I agree with my previous speaker. So as long as we don't know what our leaks are doing to our patients on the long term, we should aim for no residual leak in every patient. It may also lead to less complication and less procedural failure. So thanks a lot for your attention. And the last question again. So the future of imaging, as after this presentation, what do you think is the future? Eyes, echo, echo-fusion, echo-only, or fluoroscopy? So please vote again. So great. So Echo-fluoroscopy won in advance and it won after. Thanks a lot for your attention.
So,
can you answer yourself the question? What's your technique of the future?
My personal opinion is I totally agree with you. I think what we really need is real-time imaging, yeah? And right at the moment we get it with a combination of both. And I think in future, so the 3D technology will improve. There's also something in the pipeline, it will improve. And I think this is the future imaging technique in my eyes, yeah.
Nina, thanks for this excellent overview. What is your current working hours in CathLab? How do you do the occlusion? And if you had no money restriction, what technique of your demonstrated technology would you like to use next week?
Okay, so the current workhorse, as I guess in every lab, is a combination of 2D TEE and 3D, and it works quite nice. But if I could choose everything, yeah, I would choose the echo imaging fluoro combination.
Okay. Okay,
yeah.
Thank you. Thanks a lot. Thank you.